ready to go, Dr. Smedley.
All right, good morning, everyone. It is nice to see some people here in person as well this morning. We're going to go ahead and call to order at 9 a.m. If anyone who is online, if we can just do a quick audio check and let us know if the audio is okay.
I'm not having any trouble hearing you. You guys are pretty clear.
Excellent, thank you so much. All right, we will go ahead and do roll call, shall we?
Andrew Tang. Anthony Griffith. Brent Burgett. Brent, can you get your audio going? Can you just interrupt? Thank you. Charles Hu.
Here, can you hear me?
Oh, thank you. I hear Brent and I hear Charles. Krista Chant. Okay. Chris, when you get your audio going, likewise, just interrupt. Clifford Jones. David Notrika. Debbie Johnson.
Present.
Edgar Bissonette.
Here.
Thank you. Franco Castro Marin.
Here.
Gail Bradley. Present. Garth Gamer.
Present.
Herman Butler. Iman Pfizerfan. Judy Baum. Melissa Anderson.
Present.
Nirav Patel.
Present.
Philip Johnson.
Present.
Rod Reed.
Present.
Sandy Nygaard.
Present.
Sean Bowker. Sarah Johnson.
Present.
And Vicki Bennett. Present. 1, 2, 3.
Hey, Shelley, this is Krista Chan. I apologize. I couldn't unmute quick enough. I'm here also.
Thank you. I count 16. We have quorum.
All right, thank you very much. Anyone who is present that missed the roll call, please just send us a message and let us know that you are online so we can capture your attendance as well. A few housekeeping items. The meeting is being recorded, so just a reminder that everything said in the meeting will be part of the public recording that is posted to the Bureau's website. So just a reminder about that piece. The attendance report is attached in your packets. A reminder, if you missed 2 or more consecutive meetings, the Bureau will contact you to see if you're still interested in participating in the committee. Vacancy report, for the first time in a long time, we actually have no vacancies, which is very exciting. So we are fully have a full committee here. We do want to welcome a few new members to the committee. Our 2 new members that we'd like to welcome are Trooper Edgar Bissonette. I'm hoping I pronounced your name correctly. And Deputy Chief Brian Stevens. So welcome both of you to the staff committee. Next on the agenda, just wanted to let the group know that the Bureau was awarded a 4-year grant for AR. This is a grant we had previously, working with some opioid initiatives, specifically with law enforcement and EMT-only agencies. That grant finished a few months ago. We had applied for a new grant and did get awarded an additional 4 years for that grant. That will be starting on October 1st. We did change this grant a little bit moving forward. We wanted to have a focus and ability to do more education on naloxone leave behind, recognizing that in our last grant program, that was not an option for us to do. So we are excited that we have funding to help support that. We also did include with this grant application funding to help a partial FTE, recognizing that the Bureau's work staff is pretty kind of full as it is, and so we do need some additional bodies to help move these initiatives forward. On the agenda, you will see there's a link to our naloxone leave behind website. On that website, we have a number of resources available, including educational PowerPoints, how to order naloxone, and also an optional educational pamphlet to go out with naloxone. As we go live with the grant, we will make sure we get quite a bit of messaging out to EMS. The department department, ADHS is going through a little bit of transition of different grant cycles. So the grant cycle that ADHS has had for the Office of Injury Prevention for naloxone, they are starting to finish that cycle, and we will have another one. So we definitely will be able to support the naloxone. Where that comes from may shift a little bit in the next few months. Another exciting update, the Education Committee met to really try to address the ACS field triage guidelines that this board approved and have come together with a really good educational curriculum. I did not think that one meeting would work to get that curriculum created, but they did manage to actually pull that together. I think that will be a great resource. The goal from the Education Committee is that they are going to record that and have it done in what's called a articulate format. So it's actually a program that any department will be able to upload to your training platform. So we hope to have that available before the end of the calendar year, really to go live with the new field triage guideline in 2023. So really a big thank you to the Education Committee who took on that big project. As we look at kind of the change in the field triage for the first time since 2011, staff recognized that there was quite a bit of education that needed to be done on that. And the Education Committee really took it upon themselves to help us put together a program that people can use. Any questions on that? Right. Next up, Shelley, if you can project the 2023 meeting schedule, please.
Yeah, we're getting some comments that it's hard to hear you. It might be this tower,
Okay.
but if you could angle up a little bit. I just have to yell. Just yell.
I'm definitely turning my camera off because I have to look at the ceiling so you guys aren't all looking at my nose all meeting. Sandy, is this any better?
In Toronto.
It's a little. It's really hard to hear everybody in the room except those that are actually on the call from outside.
Got it, okay. Troubleshoot that. Do we have a microphone or anything we can plug in? I
don't have one. I can call room services.
The other option, Shelley, is when I'm speaking, if we can mute the room, I can use my computer and see if that's better. Do you want to try muting the room quickly and see if that works?
All right, we're gonna.
I'm gonna call the room services people. Maybe, are we off mute?
Yeah, we're off. All right, so I see a little troubleshooting TJ put in the messages in if you turn on captions, it can help, and he said it's pretty accurate, so you'll probably get hopefully 95% of what it says accurately. We are trying to see if we could use my computer, but we got quite a bit of feedback, so our apologies about that. The other thing that has helped with these meetings is if you use a headset, I found that definitely helps the audio. That's what we had suggested last time for troubleshooting, and people, when they plugged in their headset to their computer, seem to get better audio with that. So maybe something to try again. Next, I will turn it over to Bureau Chief Garcia for the Bureau report.
All right, and Sandy, if I speak up loudly, are you able to hear me?
Yes, I can hear you fine now. Unfortunately, I'm not anywhere near a headset. I'm actually off campus and very remote.
Right. Well, we will do our best to try to speak up so the folks on the line can hear us. I just want to say thank you so much to the folks, especially the ones here in the room today. I know quite a few of you traveled for this meeting, and we appreciate being able to see you. Earlier in the week, we also got to meet with the Trauma Program Managers Work Group, and just seeing folks together in person after the last couple years, it really is nice to be able to gather together again and have these meetings. So I guess I'll start by acknowledging that it is Suicide Awareness Month, the month of September. The department wanted to share that we do have suicide prevention materials that are available on the state's website at azhealth.gov. Most recently, over the summer, you all know that the 988 Suicide Prevention Hotline has launched. And we want to make sure that folks know that that is a resource that is available in Arizona. 988 is live. And we are happy to provide updates on that if there are any questions. There are some federal updates that we wanted to make sure that this group is aware of. We will be providing some additional legislative updates at the EMS Council meeting today. But just some notes for the State Trauma Advisory Board to keep track of. We are aware that there are some indirect impacts to trauma centers based on the No Surprises Billing Act that went into effect federally at the beginning of this calendar year. We are going to do our best to try to keep track of how that No Surprises Billing Act may continue to impact our healthcare centers, and especially how it currently impacts our air ambulance providers. Right now, there is no impact to ground ambulance providers. That is not currently included in the act, but more to come on that is what we are hearing. Also, NHTSA recently let us know that there is a notice of public rulemaking that governs how the federal highway safety funds are used to reduce injuries and fatalities related to motor vehicle accidents. We want to make sure that we are sharing that notice that is available for public comment currently, because there are potential impacts to how states are funded with these funds, SEAM response, and potentially trauma system capabilities as well. So we will keep the group updated on any of these federal updates that have potential impacts to our trauma system moving forward. We are excited today to share with the group, it is that time of year, the State Trauma Advisory Board annual report, which includes a trauma system snapshot that we will display here shortly. We would be remiss if we did not thank everybody in this room for your contributions to that report. Of course, it would not be possible without our 47 trauma centers and all the work that you all do. So certainly we are proud to be able to display that and go through some of the high-level system snapshots that are available that we'll display here in just a moment. Before we get to that, something that we expect to be talking about as we move to the annual report this afternoon, or I'm sorry, this morning, we have been having discussions in advance, being proactive, that there will be a new trauma registry in our future here in the state in the next couple of years. We look forward to continuing those conversations with stakeholders to make sure that we are planning appropriately for that type of transition. I don't think it's a surprise to anyone on the board or participating in the meeting today that the Trauma One system that we all use here in the state is being phased out by the vendor. And we will be having more conversations in the near future about what the future of the trauma registry looks like. Next up on the agenda, we do have new Bureau staff with us today that we wanted to quickly introduce to our board. We have Russ Lindholm. Oh, thank you very much. For the folks on the line, is this audio any better if I speak into the mic?
No, it's not.
All right, Steve, I'm gonna hand this mic back to you. If I just continue yelling into the ceiling, can you hear us better?
Yes.
Yes.
Okay, we're gonna stick with our ceiling tiles for now. Thank you, Steve. So we want to quickly introduce our new Bureau team members. We have Russ Lindholm that's here with us in person today. I know the folks on the line can't see you because we don't have a camera in the room. But we have Russ who comes to us with quite a bit of EMS experience. Is it 30 years, Russ?
32.
32 years of EMS experience. He is an EMS regional coordinator for the Bureau, and we are looking forward to working with you, Russ.
Thank you.
We also have Stephen Ferris, who has joined us. I think you're, what, 4 days in at this point?
Yeah, 4 days.
And welcome to the Bureau. We know that you just landed safely back in the U.S., and we're happy to have you here. Is there anything that, not to put you on the spot, but is there anything that you guys would like to share with the group?
It's great to be here. I've only been here a few more days than Stefan has, and it's been great so far. It's been great meeting everybody, and I'm just a sponge right now, absorbing everything. So it's good to be here.
Likewise, everybody's been very nice and helpful, and just been doing the online training right now, and it's been interesting, and looking forward to getting out with Margot and getting some skills experience.
Well, thank you for being here. These folks are great resources, and we look forward to making them available to everybody as EMS region coordinators that work with our 4 regions closely. The next thing we have on the agenda is just a quick announcement that there is a scope of practice update and public comment opportunity. EMS scope of practice, table 5.1, has been updated to align with the recommendations that we have received from the Medical Direction Commission, and also in alignment with national standards. That public comment period will be open through this weekend. I believe we've received about 20 comments so far. We will be reviewing those, and we look forward to future discussions on that scope of practice update.
Can you try the mic now?
All right, one more mic check. How do we sound now?
Still no?
Louder, please. You've done great, Rachel.
Okay, so on the line, I'm going to continue to yell into the ceiling tiles if that didn't help. Thank you, guys. Anything to add on scope of practice update?
No, definitely just want to ask the community to please provide any feedback. This has been a big ask from a number of stakeholders. I think between Noreen and I, we are probably getting weekly emails or phone calls requesting some of these updates. So if you have a public comment just in support or against the update, please make sure that you add that to the public comment section. So.
Couple more things on our Bureau report. I know we don't want to delay too much, but we do have the Arizona Trauma System snapshot that we can just pop up on the screen here so you guys can take a glimpse at it. Our trauma program managers got a preview of this on Tuesday, and we look forward to sharing some of these highlights as we move through the STAB annual report in our agenda later today. I know that this doesn't tell anybody in this room anything that they don't already know, but it does highlight that we have 500,000 injuries that receive care at our healthcare facilities here in the state. Of those injuries, 65,000 are trauma incidents that receive care at a trauma center here in our state. And when you break those injuries down further, we have, as you can see here, deaths by mechanism of injury. Our highest proportion of mortality is firearms, followed by motor vehicle accidents. If we scroll a little bit further down, I won't get into detail, but I'll just share that we did break out top mechanisms of injury by overall and pediatrics, ages 0 to 17. And it is extraordinary to see the differences, and that child abuse emerges as one of the top mechanisms of injury in our state for pediatric cases, and firearms continues to be the highest cause of death for pediatric traumatic injuries. We tried to highlight some risk and protective factors and opportunities for injury prevention moving forward. Certainly, we look forward to talking with STAB about any recommendations you have with how we might be able to enhance some of these opportunities for injury prevention and recommendations that we may push out throughout the state. We anticipate doing a blog and or presser to highlight some of this information, and we really appreciate your feedback on these subjects. Shelley, we can keep moving forward. Noreen, I believe you're on next.
We do have a comment in the chat from Dr. Gamer. He hates that we lost Russ to us.
Thank you, Doctor.
Get off mute quick enough.
And I just wanted to add in regards to the snapshot, some of the additions that were added compared to last year were requests from this board. So please take some time to review the snapshot that's attached in your agenda, or it's not attached, but we can make sure it's available. We definitely take input from this community to figure out what we would like to add to that. So a big thank you to Julia Benton who put this together. A big thank you as well to the board who did make some suggestions as well.
We have another comment on the chat from Dr. Katsurin. Would like to see the drugs and alcohol influence broken down and specified.
I like that recommendation. I think we should definitely try that.
And then Dr. Gamer, I don't know if you still have your hand raised for another question.
I was wondering, and maybe I missed it, drowning considered a mechanism, especially
Drowning.
pediatric. for pediatrics, or is that population left out of the report?
Probably just lower in the line.
The drowning is, I mean, the way we collect the data on drowning, it's not, and, I mean, I don't, somebody else can, maybe you wanna talk about the qualifying criteria, because I think what I know is that the drowning is not collected as standard by all the trauma centers,
Drowning is not in the inclusion criteria, only unless it's a trauma.
If there's like an associated injury or suspected injury and they make it an activation or something, then it becomes part of the inclusion criteria.
Okay, so drowning doesn't give a full picture over here in our trauma registry.
But Dr. Gamer, to your point, we do have the EMS snapshot that the Bureau puts together as well, and we can certainly try to make sure that for pediatric component for the Bureau snapshot or the pediatric snapshot that we include information about drowning. But unfortunately, just the way that many of these cases do occur, they are isolated without secondary injury, so they often are not transported to a trauma center and would not fall into ASTR, which is kind of how we get their data for this report.
Absolutely understand. Thank you for that explanation.
Just a reminder for the trauma centers on the call that we do have a rule that requires trauma centers to notify us within 3 days if there's a change in their ability to meet the requirements of their level that's going to last more than 7 days. So just want to remind folks of that. Also, this year, 2023, is the anniversary, 5th anniversary of our trauma rules. And we will be doing a 5-year review. So that doesn't mean that of the trauma rules, Article 13, that doesn't mean we can change the rules. It just means that we will be reviewing those and looking for feedback from our stakeholders. That's all I have.
Thank you, Noreen. And I realized I did get distracted by some of our audio issues. We do have an updated 2023 calendar in the packet. So if you could please make sure that you double check that to ensure there aren't any significant conflicts. Shelley does a great job of looking at all the major calendars and events that we are aware of. But if you could just make sure that you double check and see if you do see a huge conflict, that you let us know so we can reschedule. All right, next we will move to the standing committee report. First, is Sean on the line for attendance?
No, she was unable to attend, but I have the draft minutes here. If you want me to do a brief.
Sure, thank you.
All right, I'll stand by the scaling trial. At the last TEPI meeting on July 21st, they approved the minutes. They discussed fall data for ground level fall with hip fractures, along with destination data, what AZPRS has and what ASTR has. They also discussed the trauma snapshot, age defining discussion, and then patient transport trends over time. Ms. Chicani requested more info for clarification on how to analyze that data. And then the last item was discuss trauma scene times, but that discussion ended with no further action.
All right, thank you, Shelley. Next up, Sandy for education report.
Stand by 1 second, I'm pulling it up. Yes, we also met July the 21st, and we welcomed our new member, Dr. Jason Johnson. Chief Garcia welcomed the new Bureau staff and gave us some legislative and rule updates and data management transitions. We talked about the, Dr. Bradley talked about the naloxone leave behind program and the new, talked about the ADHS opioid website, which is very informational. The discussion and action items, we approved the draft minutes. We also approved forming a work group to create training on ACS field triage guidelines. We had a training program and NREMT update, which was very informative from the National Registry. We discussed creating the training curriculum for the STRs, approved the report from the work group to review the LifeVest resources, And we also approved forming a work group to make training on death notification. And Dr. Bradley gave background on this topic, and so we did have a work group, and it was approved. So, and that's kind of a brief update of what we did. Thank you.
All right, thank you, Sandy. Next up, a PMD update.
This
Dr.
is Franco. Can you
Ramirez?
hear me?
Yes, go ahead.
All right, thank you. So I've got 2 sets of minutes to review with you. The first minutes were from the PMD Standing Committee on July 21st. We met at 1200 hours. We welcomed new members, paramedic Mark Hansen, as well as Dr. Philip Hannon for Southern Arizona, who are now representing. As we had bureau updates, including Chief Garcia announcing a new license management system for EMCTs, updates on the opioid website, naloxone leave behind program, Arizona Suicide Prevention program, as well as the National Suicide Prevention Lifeline and Crisis Lifeline. As far as agenda items, we began our slow and deliberate process to update our T3Gs from start to finish. And so that is taking the balance of the agenda time now. It looks like in the meeting on the 21st, we took a look at rapid sequence intubation as an STR. We took a look at epic TBI, traumatic brain injury, universal care, syncope, stroke, anaphylaxis, altered mental status. And then ran out of time at that point and had to table a couple of different items. Then we met again on a special agenda meeting on August 30th at 1 p.m. And at that point went through, let's see, just basically continued the discussion and approval process with further T3Gs. I apologize, I don't have an exact list of what was completed on that day. But we did add, looks like a partial list added shock, sepsis, nausea, vomiting. We took a good look at the refusal guideline, which has now been renamed informed consent / no treatment / no transport. We took a look at cardiac arrest, obvious death, DNR / advanced directives, and medical termination of resuscitation. And we have our next meeting scheduled for November 17th at 1200 hours.
All right, thank you very much. Next up for Trauma Managers Work Group, Kara.
Hi, good morning, everyone. We actually just met, like Chief Garcia noted, on Tuesday. When our group met, we had a really, really great discussion, both in person and hybrid. It was wonderful to be back and see so many faces in person. Thank you to Abrazo West Trauma Center for hosting us all. While we were there, we had an update from Noreen and Kim from the Bureau from a state trauma perspective. Chief Garcia did, as she mentioned, also provide us with the trauma snapshot for the trauma program managers review. And then we had some education on falls that was provided by one of the surgeons, Dr. Olson at Abrazo West. Our discussion continued with the discussion about the state of our trauma registry. The state and the Bureau are doing a phenomenal job at keeping all of the trauma program managers involved and in the know. There's been wonderful discussion about the options that are in front of us as we move forward and what's going to be the best choice for the state of Arizona moving forward. So there will be continued discussion, and I'm sure many of you on the board are well aware of some of that discussion that's going on about the state of our registry system. We also discussed about planning our 2023 meetings. So we will be working on developing that schedule. If there's any interest from anyone on this call that is not currently a part of the Arizona Trauma Program Manager Work Group and wants to be, please reach out and let us know. We welcome having new faces join and attend us. And that's, I think, the entirety of our report.
All right, thank you very much, Kara. Next up, Adam for a patient's report. Oh, sorry, was there a? Dale might be on. Dr. Woolrich, are you on to give the PACES report?
If not, I can go.
I see him online, but I don't know.
Well, if, Dale, if you want to jump in, no problem, but I'll go ahead. Are you there?
Yeah, apologies. I defined my mute button. I'm stepping in the meeting and wasn't prepared for the report, so I'll defer to you, Adam, and I apologize to the group.
Oh, no worries at all, sir. Just a couple of really short updates. PACES has a piece of education in front of the Education Committee for pediatric behavioral training. And then, in addition, we are very busy in writing a new grant. Our grant cycle is ending on late April, and we are writing the new grant for that, and we have an increased funding ceiling for that. So we're very happy with that, and that's due in early November, and that's what we are feverishly working on. That's all I got.
Thank you, Adam. All right, next for discussion and action items. First up, if we can get a motion to discuss, amend, and approve the draft SAT meeting minutes from May 19th. Those are in your packet, and Shelley will display those as well.
Motion to approve.
Thanks, Sandy. Can I get a second?
Second.
Thank you. Was that Debbie?
Yes.
All right, thank you very much. All right, as Shelley scrolls through the meeting minutes, are there any recommended amendments or updates? All right, hearing none, since we are still in a hybrid format, I will go for anyone opposed to approving the meeting minutes as displayed, please say nay. Hearing none, any abstentions? All those in favor, please say aye or type it in the chat.
Aye.
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 All right, meeting minutes are approved. Thank you. Next on the agenda is to discuss, amend, and approve the draft SAT meeting minutes for the special meeting from June 27th. If I can get a motion, please.
So moved.
That's Sandy again.
Yes.
Yes, thank you. And if anyone making a motion or second, if you could please state your name so we can capture that for the record. Can I get a second, please?
Krista Channel, second.
Thank you. All right, we will scroll through these. This was for the special meeting to review the ATS field triage update. Pretty brief minutes there. Are there any recommended amendments? Hearing none. Any opposed, please say nay. Any abstentions? All those in favor, please say aye or type it in the chat.
Aye.
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 All right, next, I was just going to see, is Dr. Foster on the line yet?
He communicated his day got kind of chaotic, so I'm not sure.
Okay. All right, we will table items C and see if he's able to join us. In the meantime, then we will go to item D on the agenda, to discuss, amend, and approve the draft annual staff report. If I can get a motion, please.
So moved. This is Gamer.
Thank you, Dr. Gamer. Can I get a second, please?
I was gonna, yes, if we have time, do we have time to go through some of the staff report?
That's the
prior
plan,
to-
yes. We just have to actually get a motion to discuss. Yes, thank you.
This is Debbie, second.
All right, thank you, Debbie. All right, we can go ahead and open the report. Typically what we do is Vatsal will kind of run through some of the highlights on the report here, and then we will open it up for comments and questions. So Vatsal, I will turn that over to you.
Thank you, Dr. Bradley. I hope you guys can hear me. Okay. I am gonna go directly to the page number 15 of the STAR report, and that's our trauma snapshot, and Dr. Bradley described that in the morning. That is, and Julia has done a wonderful job of putting all this information into such a wonderful graphic page, and I think we have received quite a bit of positive feedback from the community. They are liking it, and we will keep on doing this snapshot every year now. Let's go through the details of some of the statistics. As you can see in the graph, in the figure 1, 2021, now, we are back to our increase in the trauma cases and the rate. You know, in last year, we observed a dip in the trauma rate because of the COVID lockdown. People were staying home and we experienced less trauma. And then in 2021, now we are back to 65,396 cases, which is a lot, actually quite a bit of a jump compared to the last year, and which brings our trauma rate to 898 per 100,000. So when in 2010, we started with 400 cases per 100,000, and now we are more than double. No doubt we have a number of trauma centers have increased over the years, but still going double is quite a big jump in the trauma rate in our state. What we see in figure 2, age and gender, we see that 65-year-old are affected quite a bit higher compared to other age groups, both among male and female. And race-specific trauma rate, if I'm looking at it, American Indian and white. Now, you know, I think the white have the higher rate compared to the American Indian. That it usually used to be an American Indian. But I just have one disclaimer over here. This time, I had to use a different population denominators. We used a census and not a state demographers, which we usually use in our for our STEM report. And the denominators are currently not available. They are working right now to give me the state demographers denominators. So as soon as those denominators come, I'm going to update this graph, the rate graph. Okay, and right now, if we see the median, which looks very high compared to this year's rate, and that is because the median is coming from different population denominators, and I'm using a census right now. So there is going to be a slight difference. We'll observe it, but I'm going to update it as soon as I have the new denominators available. The mechanism of injury, as always, falls and motor vehicle occupants, they basically make up for 70% of our trauma cases. Like 2/3 of cases belong to these two main mechanisms of injury. 47% fall and 18% empty occupant. Same pattern, I'm observing it in the next page when we narrowed it down the populations to just injury, very severe trauma cases, which is ISS less than 50. Page 19, we'll see some difference in the pattern between male and females regarding the types of mechanisms of injury. And if you see, like, you know, females, like 60% were falls, whereas 40% in males were the falls for the cause. Some of the, like, you know, firearm is 0%, whereas in male we see that 4% of mechanism of injury firearm. Sorry.
I just scroll down just a little bit.
Oh, slow down a little bit. Scroll down. Sorry, I'm looking at my notes, and then, yeah, that's the one, male and female. All right. Let's go to page 22. This particular table over here, the table 10, I again do not have this detailed age breakdown for the population. Again, census, I don't have that available. So this population proportion is exactly same as the last year report. Again, I will update it as soon as I have the new data available to me. So but if the proportion should not change that much, so I'm like, okay, that's okay to keep it, you know, for that right now. What we see in the trauma mortality, if you see the figure 12, 65 years and older, they have a very high mortality. Males have higher mortality compared to females. And the next page, please. Males have higher, and race and ethnicity, the whites have higher mortality compared to any other race and ethnicity. The figure 15, I have not updated that figure. Again, that database is also not available for the latest year. Just like that, we are just ahead of all other databases. Anyway, so that's, again, it's an old figure, but we will update it whenever the database is available to me.
Russell, can I just make a comment and share with people how amazing you and the team are? Because truly, these databases and reports typically lag 2 years for reporting timeframes. And Boswell does this in almost close to real time when you look at some of the other databases. So this is huge, and you do a fantastic job.
Okay. Page 24, charges. Now our trauma charges close to $4 billion, and the reimbursement is staying kind of almost similar, like 12%, in the range of 12%. Let's go to the page number 26. Let's look at some of the risk factors. Drug and alcohol, as we see, like 25%, like the quarter of trauma patients had some kind of suspected or confirmed use of either drug or alcohol. And we see the pattern still exists, as I've been telling every year, that what we are seeing is that the drug proportion of people suspected drug or drug is higher among the younger age population, and then as after 45, it is like kind of alcohol is kind of between that. There is not much difference between alcohol and drug, but more alcohol. But there is a quite bit of disproportionate between the drug and alcohol, especially among, look at the 15 and 17 years old, 17% drugs and 6% alcohol, which used to be before 2010 or I think 11, it should be other way around.
And just one thing to add to this, I know there was a question about clarifying that on the snapshot. Is the ask to add that to the snapshot, or just wanted to make sure that we had that captured somewhere in our staff report? Because we do have the breakdown by age group in the staff report. So I want to make sure we have that readily available. But if there is an ask to also try to add that to the snapshot, we may have to kind of look at
have the space wise,
taking something else off.
Yeah, it was to see if it would be somewhere in the stab report, the breakdown of what drugs and how those break down in comparison to alcohol. Thank you.
Thanks. And are you looking for specific drugs or just drug versus alcohol?
Specific drug is if that could be known. It'd be interesting to see how much of this is marijuana as opposed to other substances that are considered illegal, and sort of that breakdown.
And in the room, we have a comment from Vicki.
Yeah, I was just going to support that. I think historically we talked about looking at marijuana once it became legal for recreational use. I know some states, especially Colorado, have studied it and have seen a trend in injuries related to that. So I think it would be interesting to see.
Vicki, would you advise that we have a supplemental report or add this information in the annual report? Our annual report is really getting bigger and bigger. I mean, I can include it, no problem, but if we want a separate report on drug and alcohol, looking into quite with many other details, we can even do that.
You can also do it a separate snapshot page, like you've done for some of the other things, maybe?
Yeah. Yeah, certainly I think between the marijuana, first becoming medicinal and now becoming legal, and then also with the increase in fentanyl as a big issue statewide, that's certainly something that we probably want to add to that. So especially as Boswell points out, we've seen that transition in the 15 to 17-year-old age group. That may be useful trends to monitor. So it might be something that's useful for us to look at that extends beyond the report, but certainly can produce that. So thank you for bringing those up.
Let's turn to page 27, next page, which talks about the protective devices. And this page, we have been in this percent since many years now, like 68% cast restraint use, and that's been steady. We are not increasing in the cast restraint use over the years. It's steady since many, many years now. The helmet use is very low among pedal cyclists and among motorcyclists, and again, there is the same story. I mean, we don't see any changes. It's been like this since many years now.
I have a question in the chat from Dr. Gamer. Could there be some discussion of the intent pages that we skipped over?
Which page?
Which page would you like us to go back to? And we can certainly go back to that page.
Yeah.
I think it was about page number 21. I just want to know how you obtained intent on some of the. I didn't mean to interrupt. I could have waited till the end, but now that we're doing it.
So how we obtained is that CDC comes up with their metrics, which basically classifies E-codes into mechanisms and intent. So we use, and all the states uses that metrics to figure it out, the classifications, and we use the exactly same one.
Thank you.
So maybe if I can mention, as this group looks at some injury prevention options, certainly when we look at protective devices and we look at the helmet use, especially among off-road vehicle occupants, this may be really an opportunity to help get some educational out there when we think about things that we can have significant change. Especially when you look at the young age population, we have children less than 5, and only 13% are wearing some type of helmet on an off-road vehicle. Certainly this is a pretty significant thing. So as we look at different options of where this committee can take this for injury prevention, there's definitely some opportunities there.
Page 28, we talk about injury to ED arrival time, and the population is narrowed down to if the ISS score is greater than 15. And so these are kind of more severe patients. And then we see the difference between the rural and urban. The one thing we need to also look at it is the last column, which is injury time missing, and then we still have a pretty huge missing in the injury time. So I would look at this data with some caution over there because of the missing information. All right, let's go to page 29, which is the trauma rate by region. What we see over here is that the northern region has a very high trauma rate compared to all other regions. And when the 26B, the figure, is about all the trauma which is ISS greater than 15, and in that also we see the same pattern that northern region has higher compared to other regions. So, but when we look at the table 20, and if you see the last two columns over there, which are the injury cases, that comes from hospital discharge database. Can we scroll down a little bit down so you can see the table 20? What I want to point out over here is that the last two columns are injury cases that comes from hospital discharge databases. And if I calculate the rate, then the rate is basically kind of similar in the rate of like 6,000 something per 100,000. That's in little higher amounts in the southeastern region, but other than that, the regions do not differ in terms of number of injury cases. But when we go to the trauma, the northern region has a really high trauma rate. So that's kind of, that's a number of injuries, they don't differ, but it's the trauma cases. So severe trauma cases are happening more in the northern region. That's what I think it's I'm trying to say, but so we need to, we can dwell a little bit more in the regional analysis to figure it out what's going on in the northern region.
Also, I'm just going to run quickly. I see a question in the chat. Has the state of Arizona tried legislative pathways for helmet use for motorcycle drivers similar to seatbelts? I see some head nodding here.
Yeah. It's yes, several times and it gets shut down every time.
Yeah.
Yep. Okay.
Thank you. And for anyone who's not in the room, what Vicki Bennett just added, there is a requirement for anyone under the age of 18.
On all for vehicles too? On all vehicles?
Yep.
Sounds like you're
Let's go to page 32. Page 32 gives information on traumatic brain injury and mortality proportion. So there are two types of traumatic brain injury as defined by CDC injury metrics, major TBI and minor TBI. And so if I combine both the TBIs, like any kind of traumatic brain injury, it's like 30% of our trauma cases get some form of traumatic brain injury. 10% were major and 20% were minor. And we see also a very high proportion among the kids. And one of the main figure 31 shows the proportion of traumatic brain injury by mechanism. So MVT pedestrians, 47. So almost half of the pedestrians ended up getting a traumatic brain injury. And if you see child and adult abuse also, like 46% like ended up getting a traumatic brain injury. So these are the main mechanisms of, not the main mechanism of TBI, it's which mechanism of, is more likely to get traumatic brain injury. That's what the figure is.
Just a reminder for anyone on the line to please keep your phone on mute or your computer on mute. I did just mute someone, so if you need to speak, you'll have to unmute yourself. Thank you.
Star 6.
Star 6 to unmute if you're on the phone. Thank you.
Let's go to page 35. So this is a brand new section we added, and there are like many pages now. We added almost, 10 pages or something, but that's on trauma center designation. So this basically does some kind of comparative analysis by the designation. What we are seeing in figure 32 is just saying number of trauma centers from 2008 to 2021, and as you see that, we are like level 4 is where the numbers have really gone high, and obviously, we more and more level, and then I think the level from 17 or 18 after that, the level 1 is in the range of 13, 14 trauma centers.
So this was just Botzel's underselling all the work that we asked her to do, but this was an ask from the committee last year, and I think really an important part to look at as our trauma system has evolved and grown over the last decade plus. If you look at our trauma system in 2008 compared to now, there's a significant change in availability of core trauma care throughout the state of Arizona for all levels of trauma centers. And so really what we want to do is kind of look at some of this data, recognizing that many of these patients that now potentially go to a level 4 or 3 would have historically been flown to a level 1, and seeing how things have potentially changed over time. So the board had asked us to create some data looking at specifically level 1 versus 3s and 4s, and seeing what some trends may be included. So a big thank you to Bob, because this was quite a bit of additional workload, but I think it's quite useful as we move through this.
Do we want to verbalize Andrew Tang's comment from the chat?
There is a comment in the chat from Dr. Tang. Dr. Randall Freese, trauma surgeon, was a state rep who introduced helmet use bill a few years ago. It was voted down in the Transportation and Infrastructure Committee. Thank you for that update.
Figure 33 shows trauma incidents. It kind of gives us, if you can scroll down a little bit, gives us an idea of what is the volume at level 1, level 4, and level 3. So 44,000 in level 1, 6,000 level 3, and level 4 is around 40,000 incidents we are getting it from the level 4.
Sorry, is there a comment on the line?
Dr. Foster on the line?
So basically, of the 65,000 cases reported to the trauma registry this year, 44,000 were reported by level 1, level 3 reported 6,000 cases, and level 4 reported 14,000 trauma cases. We have page number 37. We talk about the incidence of mechanism of injury. So it breaks down by level 1, level 3, level 4. So particularly we can see, which by level, designation level, what kind of injuries they are seeing it more. And I guess the fall and motor vehicle occupant, MVD occupant still takes the number 1 and 2 mechanism of injury.
I think there are some interesting trends when you look at the different levels. Certainly the falls and motor vehicle crashes are still the top 2, but there is a little bit of difference in numbers, especially when you look at level 3 versus level 1 for the fall percentages. So interesting that level 4 and level 1, those percents are about equal, but definitely interesting data to look comparing the different level of trauma centers.
So then the mortality proportion. So we have level 1 have a higher mortality compared to level 3 and level 4 for obvious reasons. Level 1 and level 3 higher pediatric patients also. What are the top 6 mechanisms? So for level 1, what were the top 6 mechanisms of injury? For level 3, and then for level 4. So next page 39 and 40 shows the top 6 mechanism of injury by year for each of the designation levels. Yes, then we can go, but this is time. Figure 37 talks about trauma proportion by injury severity score, and if you see the proportion among the level 1, we can see that little higher proportions of severely injured patients compared to the level 3 and level 4. The mode of transportation, again, we see this kind of an expected pattern that air transport was little higher among level 1, and it's not that level 3 and level 4. So that's kind of, and then.
And just to kind of point out, I think there is definitely, obviously between a level 1 and level 4, there's a significant difference there. We do see the POV, if you look at injury severity score of POV of level 1 through level 4, a significant difference there. We're going from 2% to 30%. So yeah, pretty substantial. And this certainly may be due to the fact that many level 4s are in our rural communities where that's the only access to care. And so we recognize that this may be the method that many patients are taken to the hospital in those settings. So definitely a big difference in percentages there.
In the table 33, it talks about injury ED arrival time. This is kind of a golden hour. What we are talking about is injury severity score greater than 15, and then by designation level, what are we getting it? So level 1, rural, 104 and urban is 46 minutes. Whereas in level 3, rural and urban, 47 to 64 minutes, getting better. And the level 4, rural is 62 to 60 minutes. So it's only when the level 1 and in the rural injury, the median time is higher, which kind of maybe makes sense is that most of our level 1 are in the urban area, except for the 2 not. Now, traumatic brain injury and mortality proportion by designation. So those tables are basically now the TBI cases are broken down by each of the designation levels and by each group. That's it. Any other questions, comments?
Now when we clap for you, Buffalo.
That's great.
Yes. Thank you for the summary, Buffalo. That was excellent. And, a big thank you. I think it is useful, especially when you look at that graph and that shows the change in our trauma system in terms of types and numbers of trauma centers in a decade plus. That's really been a substantial change for Arizona. And so really want to highlight how this has helped our trauma system evolve in the state. I know we've had some questions during the meeting. Are there any other further questions or items the group would like to look at further? We definitely have the time to do this. This is our main agenda item for today.
Yeah, Dr. Phil Johnson. Hi, this is Dr. Phil Johnson. I echo what you just said. I've been on STAB long enough to know that we used to go through these reports and all we had was a level 1 trauma center. And I just really hats off to the STAB for working hard. The number of level 4s now are significant. Summit was the first level 4 on there, and level 3s, and even the level 1s are increased. And I just think that that's a good thing. And we've done some incredible things in the last 10 plus years. I do have a letter that I was asked to submit to STAB from the trauma director here at Summit. I mean, not the director, just the nursing manager. And I forwarded that to Shelley, and it has to do with the Arizona Trauma Program Managers Group regarding the Trauma Registry. And I think it could just be put on the agenda for next time. I have forwarded that to Shelley.
Vicki, go ahead. Thank you, Dr. Johnson.
This is Vicki. Just to continue on the thought with what Dr. Johnson just mentioned, as I was at the meeting with the discussion the other day with the Trauma Program Managers Work Group, And what we felt perhaps was a good way to approach this, one, recognize the whole team for all of the tremendous work you've done, the amount of resources it takes to continue to support what is needed to advance the care of trauma in our state, as well as support it by evidence. And so the work group discussed the state. We're very appreciative. We acknowledge the proactive approach the state has been taking to involve us in all the decision making about the proposed changes that are going to be coming with our future of our registry. And we wanted to make a recommendation, basically that we know that the data and the trauma registry is a statutory requirement. We know that it's required of all trauma centers. It's also required of the American College of Surgeons, verified centers. Data from the trauma registry is the driving force for our performance improvement, injury prevention efforts, community programs, trauma research, and state-driven projects. The Trauma Program Manager Work Group proposes an additional amendment to the staff report to include a statement about the magnitude of resources that's needed, the additional resources to support upcoming changes to our registry. This is 2022, and we can no longer look at things like we've looked at them in the past. Resources are going to be needed going forward to be able to continue to support data such as this to advance all of our centers as well as state.
Well said. Thank you, Vicki. Any further questions or comments regarding the staff report?
Hi, this is Kara from Phoenix. I just have a question to Vatsal and her team in regarding to the child abuse data that was on the snapshot for our pediatric population. I'm interested in that number for that we show from the state as overall child abuse numbers. While it still does hit as one of our top mechanisms for pediatrics, I'm surprised at the number. I don't know about other centers that are managing pediatrics and what their thoughts are, but the overall rate that we have listed for child abuse seems a bit low. And I'm wondering if there's an opportunity there for us as a state to maybe clean up our data and how we're reporting that out so that number is a little bit more reflective of what's actually occurring.
So definitely a good point. Our data for this report is pulled from ASTR. So patients who are transported to a non-trauma center, that data would not fall into this report because they don't report data to ASTR. So certainly that is kind of a limitation with all of our data. That's why we did include kind of the DAYS component, which is the death database for the state of Arizona, because we recognize that there are traumatic injured patients that are terminated or called on scene and are not transported. And because they're not transported to the hospital, they don't get into this ASTR and the trauma database. So definitely a good point, but I think that would be tough in terms of the trauma snapshot to change those numbers based on the fact that this is specifically pediatric patients transported to a trauma center.
Right, and if you see on the snapshot on the page 15, the first thing we say that, okay, so ASTR reported 65,000 cases and hospital discharge database, the injury related cases are 474,000 cases, which is, so the trauma registry reported around 14 to 15% of those hospital discharge injury cases. And it's a very trauma specific database.
Does that answer your question, Kara?
Yeah, it definitely does. Thank you. I appreciate that.
Kara, this is Rachel. To kind of piggyback on what you're sharing, if we were to do any blogs or press releases about this information, would it be helpful for us to make sure that we are highlighting that this information is only inclusive of the trauma registry and those patients served at a trauma center, and that we recognize that many things like child abuse may be more widespread and deserve looking at additional data sets to better understand those things? Is that what you're getting at?
Yes. I definitely think that would be a great way of framing it, for sure.
Yeah, Rachel, great idea. And anything to say that this is just represents the tip of the iceberg with respect to child abuse. Thank you.
Yeah, Rachel, this is Debbie. I concur as well.
Thank you. Great discussion points. I think it is helpful to just kind of remind ourselves sometimes what the actual data set is that produces this report, recognizing that not all patients will go to a trauma center and end up in this patient population. Are there any other further comments or questions about the report before we go through the approval?
Hey, this is Andy Tang from Tucson. I do have one question.
All right, go ahead, Andy.
And this is and I've brought this point up before during the previous dissemination about the reports. I'm referring to page 29. Looking at the northern areas of the state, their trauma rate is significantly high and disturbingly high, and the severities, the degree of severity of injury also is significantly higher than the rest parts of the state. I mean, it's good that the mortality is not terribly worse, but I'm just wondering, are there any comments or any public health efforts to kind of look into this particular issue? You know, I'm referring specifically to the top two graphs on page 29.
Thank you, Andy.
In the past, this number has been high also because it represents most of the Indian Nation. It's Navajo Nation and also patients coming in from the Grand Canyon, that whole northern section. So Bato may be able to speak more on that, but this is a population that's captured in very rural areas.
Right.
Yeah.
So we can definitely do a deep analysis to figure it out what's going on. But one of the things also we need to keep in mind that trauma inclusion criteria by these trauma hospitals in the northern region, do they differ a lot compared to other regions? Are they reporting more trauma cases than compared to other trauma regions where they are maybe not qualified as a trauma? That also can give rise to increase in northern region. So certainly that there are many factors over here which we have to look at it, but I'm happy to do the deep dive into the regional analysis to figure it out.
And I think one of the things, if you go to the trauma snapshot, when you look at the map of trauma centers, if you look at the northern region, geographically, I think there's a bigger map in here somewhere. I just know it's on the snapshot, so I think it's there. But if you look at the northern region, you can see very clearly that there is significantly fewer access to medical care versus the rest of the state. And so that can absolutely affect both transport times, recognizing that you're going to have longer transport times to the hospital. And oftentimes patients who are in other parts of the state, even if there isn't access to a level 1, they can get to a level 3 or 4 who can stabilize them and transfer. So just something to point out, when you look at the geographic map, it's a pretty astounding. The northern region is large with very little access to care compared to other parts of the state.
And these, sorry, go ahead.
Yeah, this is Dr. Phil Johnson. I just want to support that, having worked in northern Arizona now for over 25 years at multiple institutions and multiple ERs. And it's a problem, and I think that we need to continue working on it. We can't change the fact that we're geographically isolated, and it takes a long time to get to the ERs. But we can work on issues like alcohol-related. We're close to reservations, and I know the reservations are trying to work on the alcohol-related problem. So it's a problem that I've been familiar with for over 20 years, and it's continued to be a problem, and we need to continue to look at it, in my opinion.
Yeah, I agree. I think, and we have been seeing this increase in northern region since now few years. So I think it would be a good idea to get into it, and we can do a deep analysis by region.
So definitely, I think that's one of the things that we can look at further is the northern region. The bigger map that's the full page is page 12. For ease of looking at that, it definitely demonstrates again, how things and geography affect that. We definitely see that with some of our just non-trauma EMS related cases where It can take a long period of time, up to 60 minutes to get, to find someone in a geographic area that's very rural with no paved roads. All those things contribute to outcomes for patients. So definitely important feedback. So thank you for bringing that up, Dr. Tang.
Gail, to add on to that, most of the hospitals in the northern regions are trauma centers. There's only 1 or 2 hospitals that I can think of, one is Chinle, that is not a trauma center. So the greatest population of patients going to the hospitals are going to trauma centers.
So we get a more representation from the northern region than any other region. That's also going to be a reason, yeah.
I do think that there's two separate issues. One is the access to care, based on what we see on this map layout of trauma centers, the geographical isolation. I understand that, but on the other hand, I think from a public health standpoint, it's an issue of, there's just more folks getting into crashes and whatnot up there. The incidence of trauma is significantly higher than the rest of the state, and the severity of injury is worse there. So I think that's a separate issue, and there's certainly room for some sort of public health efforts. I know it's easier said than done, and I've brought this up every year. We have to do better, I think.
Dr. Tang, this is Rachel. Would you also recommend that if we do, again, any blogs or pressers on this, that just as you said, highlighting access to care, particularly in our more rural communities in the state, these types of injury prevention efforts are more critical than ever, and really highlighting that demographics and injury prevention are what we need to be thinking about when we look at this data?
I do.
Thank you. So this is great discussion. Thank you, Dr. Johnson. Yes, this is great discussion. It's always nice when we have participation in these meetings versus us just talking at everyone. But really, we want to have the staff report actually affect care. So we don't want to just take the data and not do anything with the data. So as we see different trends and items that come up in the data over the years, we really want to make sure that we take some of that forward. We also always confirm anytime there are things that look like it's an anomaly or change, is this real or is this some artifactual issue that could be changing that? So a big thank you to this committee. Are there any further comments before we move towards approving the staff report?
Gail, I just want to add some quick highlights since we did not go through the executive summary with this group. The executive summary is broken down into 5 sections. It talks about Arizona's trauma system developing to include a network of urban and rural trauma centers to increase access to trauma care, although as we discussed, there are still differences observed by region. It talks about building Arizona trauma system readiness, and that requires preparing for new emerging threats, especially as we see that 1 in 10 of the injuries are considered intentional, either assault or self-harm. Next, understanding trauma system reimbursement trends and financial stability is going to be key to maintaining Arizona's trauma system capacity. We did not highlight that, although there is a whole section in this report that talks about reimbursement, and something that we know that staff is committed to monitoring and including in this report each year. Finally, we know that injury prevention efforts are critical to mitigating increases in trauma severity that overburden our healthcare system. And we also acknowledge that future resource needs we know that future, as we look ahead, there are going to be future resource needs to sustain our prepared trauma system. I think that this last section would lend itself nicely to capturing some of what was shared here and recommended by staff to be incorporated. Considering future resource needs, particularly related to the Arizona's Trauma Registry, is going to be important. And so we are happy to make sure that that is incorporated in this year's trauma report.
Thank you. And I do see in the chat, we do have 2 additional comments from Melissa Anderson and Brian Bates, echoing what has been stated by Vicki and Dr. Johnson. So if that could be a friendly amendment to the initial discussed and approved motion, if the group would like to add that to the report. So make a friendly amendment. So you can make a friendly amendment to add the request for data.
Yeah, I made a friendly amendment to add the request for data that I just said, and that you just read.
So this is specific to the, making sure there's adequate resources to support our data registry moving forward, so. All right, is there a second?
Second, Gamer.
Thank you, Dr. Gamer. All right. Any further discussion? All right, hearing none. Anyone opposed to the staff report as presented with the friendly amendment, please say nay. Hearing none. Any abstentions? All those in favor, please say aye or type aye in the chat.
Aye.
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 All right, the staff report is approved. Big thank you to everyone again. A huge project and all of the work from the trauma centers to send the data to ASTR. So thank you very much to the trauma centers and a big thank you to Boswell. So, all right. It does not look like we have Dr. Foster, so we will table that to the next time. Are there any agenda items to be considered for the next meeting? All right, call to the public. A summary of current events, those are attached on the agenda. If you have any additional events that are not listed that you would like us to help publicize, please let Shelley know. We do have some links as well on the agenda for news and conferences along with training programs for upcoming CEs. Our next meeting will be January 19th, 2023 at 0900, location to be determined. Again, thank you for everyone for being in person and on the line hybrid. And please, if you would like to join us in person, we would love to have that. Definitely the audio seems to work better in person. So with that being said, we'll go ahead and get a motion to end the meeting at 10:17, please.
Thank you.
Motion. Thank you. All right, we got a motion, meeting adjourned. Thank you, everyone.
Thank you.
Thank you, everyone.
I don't know, not right.